We would now like to invite Dr. Chris Hensman and Dr. Sanjeev Khurana for talking on improving outcomes in hernia care, why and how. So Dr. Chris Hensman is a lecturer at Monash University, partner at Lab Surgery Australia, co-founder of Valley Hospital Surgical Obesity Clinic, St. John of Gone Berwick Hospital. And he has been one of the pillars of this ANZAWR initiative, and he has been kind of, looking after right from day one about all the minutest details of these programs. So thanks, Dr. Hensman. And Dr. Sanjeev Khurana is a pediatric general surgeon and urologist at Women's and Children's Hospital, co-founder of Danny's Place Holistic Care for Children with Obesity-related Problem. So over to Dr. Hensman and Dr. Khurana.
Yeah, look, before I start, I want to thank Todd. He sort of stole a little bit my thunder, but let the video run and we'll take it from there.
Thank you. This is probably the most important lecture of the entire meeting. It's a combined talk that I'm going to do, and I urge you to pay attention to the next 20 minutes. Improving outcomes in hernia care is a critical topic if you in any way connected with a hernia surgery. I'm going to outline why there is a problem and also give you a tangible solution and show how you can be part of that solution. I've learned a couple of things from these little to known individuals, and that is have a look at their eyes. And if you want to get a secret of their success, it's about keeping your eyes on where the ball is going to land and to anticipate the trajectory. And this is the case in hernia surgery. I think that we're poised in a watershed moment, and it's not only our responsibility but a massive opportunity to make a difference. Remember, that's why you signed up to be a surgeon, and to do that I think we need to keep our eyes on what's coming up ahead. Well, there is a need to be a major paradigm shift in hernia management, and it will not happen unless we all collectively agree that there is an issue and that we all need to be involved in this process. Here's what I'm going to briefly touch base on. I'm going to talk about what is the issue, what are the issues, and in terms of the management of hernia repair. We have been focused on technique, and that's good, and I think there's no issue with that, but the focus now has to also equally be gone to outcomes and to collect data, and we'll briefly talk about that. We need data. Without data and the correct type of data, we simply cannot improve the quality of outcomes, and as we move to the next era in hernia management, this becomes a critical issue. I'm going to outline to you that it is frustrating to some extent that I still hear academics and various people talk about randomized controlled trials, and I can tell you right now what's not going to help, and that's randomized studies. So how do we transition? How do we collect the data that we need to transition and to improve the outcomes? I will also be, in the second part of this talk, be handing over to Dr. Sanjeev Khurana, who will be wearing his health informatics hat and talk about a pilot study that we're going to launch very soon under the courtesy of the ANZ Hernia Group. Let me illustrate the problem and why we need solutions and why data outcome data is so critical. This is one of many talks that are being given in this COVID era. They are fantastic talks. They're multiple. You can, for every day of the week, you can pick one up. And there have been massive advances, refinements in techniques, nuanced anatomy, new insights because of high definition views of the critical views of the posterior abdominal wall, and we've improved our understanding of mesh biology. But have a look at the topics for discussion, and you will find there is a salient absence of any outcome data that particularly with regard to long-term data and particularly with regard to patient-reported outcomes. So surgeons are basically providing data-free statements focused on what we think is important. I want to pose a question to you. Do we know that MIS, the approach is the best for all patients? What about putting in larger mesh? Is that always the best thing? Does larger mesh mean more problems for patients? And also critically, we're doing really massive operations for small hernia. Is this the right approach? So you might say, well, what is the problem? Well, we have a problem. Have a look at this flyer. This is from the United States, and hernia mesh lawsuits have exponentially increased, and 7,000 claims, various manufacturers being implicated, and 90% of them are related to mesh repair and every single complication that you know. So while we think there is no problem, patients do have problems, except we're not recording what those problems are. And you know, this is an issue that's been going on for more than 25 years. So we don't seem to have paid much attention to that. In Australia, of course, we have come to learn about this in a very sensitive way. There's been a class action against mesh placed in the pelvis, and this is an issue because it's spilled over into the hernia field as well. And so the regulator, the Therapeutic Goods Administration, have stepped in and said, okay, if you guys don't know how to fix this, we'll tell you. And so they've upclassed the hernia mesh as a class 3 device, which means that any one placing mesh must have robust means of following these patients up lifelong. And this is the risk. If we don't take a proactive step in this, we'll be told how to sort this problem out. I'll tell you what doesn't work and what will not work. This is a superseded model, if you like. The randomized controlled trial was first described in 1753. And really, it's superseded. It's a highly selected cohort of patients, not real-world data, and it's really hard to apply this to the patient sitting across your consulting room, and it's expensive. It's very slow to get results, and basically, this is not what's going to answer. It's not answered it so far, and it'll never be the solution. So what is the solution? Well, registry data we know have had a good track record. Here's a salient reminder that findings from the German Hernia Med registry on mesh from the Ethicon company was withdrawn because of findings, adverse findings from the registry data. And so we know that registries are proven, they are cost effective, but there are some issues with traditional registries, and I think that's an issue that we need to be aware of. So to remind you, we need data, we need to measure, because if we don't measure outcomes, we simply cannot improve it. And as we move into this next era in hernia care, we need to find what data we need to collect, and we need to ensure that we collect also patient-related outcome data, which are pretty critical. And to this effect, we have been working with a group in the US trying to homogenize and agree on what sort of KPIs that we are necessary to collect. And We'll talk a little bit more as time goes on. So for quality improvement in hernia surgery, I think as we transition from the volume-based, where we are paid because we're doing vast numbers, we're going to transition to the value paradigm. 101, we need to collect the data, we need to analyze it, and then we need to act on it and so forth in a continuous feedback cycle. And this is what's going to answer this massive knowledge gap we have. I'm going to hand over to Sanjeev Khurana now. And Sanjeev is a pediatric surgeon, but he's going to outline to you, and if you haven't heard this before, the learning healthcare system, and this is not reinventing the wheel. Please listen carefully, because this is the answer to what we are looking for. Thank you for your attention.
Thanks, Chris. Please roll the video. Thanks, Chris, and the organizing committee for this opportunity to present today. I am primarily a pediatric surgeon based in Adelaide with an interest in health informatics. My colleagues and I began as a research interest group 7 years ago, looking at ways to utilize machine learning in our daily practice. And this has evolved into a health informatics company which has been commissioned by the ANZ Hernia Society to run the pilot study on the use of a learning healthcare system approach towards creating a virtual clinical quality registry for patients undergoing hernia surgery. Before I describe what exactly I mean by a learning healthcare system, I would like to go over the rationale for its intended use, and lastly talk about how we intend to use it for the purpose of this trial. The concept of learning healthcare system has only recently been formalized, although its seeds were sown by an eccentric surgeon in Boston over 100 years ago, when Ernest Codman dared to suggest that surgeons should take more interest in following up their patients. It took us more than half a century after Codman to truly establish the norms of clinical quality improvement, and we are now all very familiar with the concepts of audits, clinical research, and registries. However, like so many other facets of our lives, the accelerated pace of change in this digital technology in the last 20 years has meant that our current methodologies of performing these important functions have become redundant and ripe for change. Surgical audits are currently performed as a standalone activity to confirm whether current performance meets existing standards. Audits are not the same as research because they are not designed to extend our knowledge base about a condition per se. This is primarily because of limitations around data capture. And so there is a separate, well-established knowledge creation industry within the healthcare sector now that is expensive and slow. It has also led to a significant clinician disengagement with the entire process of quality improvement. And even though big advances have been made in our understanding of how to set up a good clinical quality registry, the biggest impediment remains operational considerations such as the major costs for data collection and the burden of data collection, and also the fact that the research potential of these registries is still limited by the data set. To give you an example, the Australian federal government imposed a direct tax to the tune of $2.376 million on device manufacturers last year for the running of the National Joint Replacement Registry, more than half of which was for data services. The main reason for this expense is because the efficiency gains expected in data acquisition from the rollout of electronic medical records has not materialized. Basically because they are not fit for the purpose of quality control measures. And this, of course, has downstream effects, such as having to prioritize scarce taxpayer dollars for running registries. A solution to this problem, as proposed by the US National Academy of Science, is the learning healthcare system approach. In essence, a learning healthcare system comprises of clinicians and data scientists brought together by a modern digital platform that allows for safe and easy collection of multidimensional data. This data can then be analyzed by modern data science techniques such as machine learning, which allow much greater insight into problems related to medical conditions and their management. So in essence, this is a socio-technological system, not just a technology platform. The system is designed to be deployed alongside an electronic medical record or a paper record for that matter, and not to replace one. And because it's much easier and cheaper to configure the system, the burden of data entry by various clinical teams members, including surgeons, anesthetists, nurses, and administrative staff, can be reduced by first entering the key data elements onto this platform, which can then be pulled into the EMR as well. The system also allows for capture of data from a patient portal, which can be configured to include not just questionnaires, but newer forms of health data, such as from wearables and monitoring devices. This combined with a data visualization tool, which gives live feedback of patient identifiable data only to the treating teams. The de-identified data can be exported easily into a virtual registry for aggregation with similar data from other sites, where it can be analyzed with an expanded set of data analytical tools such as machine learning. In this manner, the learning healthcare system approach has the potential to reduce the time lag between research and practice change, allow for patient co-participation, and enable deeper understanding of problems, as well as comparisons at local population levels as never before. Most importantly, it is not just doable, but also affordable to do so. And so to this pilot study. The key stakeholders besides the clinicians at local sites are the ANZAWR Hernia Society, the Research and Evaluation Wing of the Royal Australasian College of Surgeons, the Health Data Science Group at Flinders University, South Australia, and the Commission of Excellence and Innovation in Health, South Australia. The technology platform is being built by Data Dissect and will be cloud-based. We hope to begin at the Queen Elizabeth Hospital in Adelaide in August this year. The first iteration of this learning healthcare system will include clinician and patient-facing portals, which will allow for easy capture of not just the current data set being collected by the American Hernia Society, but also the entire pre-operative process and the patient-reported outcome and expectation measures. There will also be a barcode scanner to capture the individual mesh details for every patient. The pilot study will measure some standard outcome measures that any registry would, but along with it, we will also try and answer some questions which are particularly suited to the design of a learning healthcare system, such as what is the mesh performance relative to others in different clinical situations, an ability to compare surgical techniques, cost-benefit analysis, and start the creation of some preliminary risk prediction models. We are also going to try and measure the use of this concept, the learning healthcare system, its uptake by patients and clinicians, the completeness of data that it can capture, the ease of reporting, and the compliance with national CQR guidelines. So in summary, a learning healthcare system is a single system that can enable audit, research, and virtual clinical quality registries. The two main paradigm shifts here are the ability to use data derived at the point of care for creating local learning, and also for our ability to use modern data science tools and not just conventional biostatistics to allow for incremental improvement in knowledge rather than just trying to prove or disprove a hypothesis. Ladies and gentlemen, change is imminent. This is how my Women and Children's Hospital here in Adelaide has transformed from what it looked like in the 1870s to currently, and where it's hopefully headed in the very near future. Thank you.
Thank you for that. That concludes that talk. Is there any questions or can we answer? Any comments from Todd Henniford? I'm very curious to hear some comments from him.
Well, thank you. I thought those were both excellent talks, and again, the demonstration of what we know and what we don't know and about the future, the AI stuff. We've got some really smart kids that are working with us, and so one of the interesting things about using the AI, we have a Celia Yuza, who I just mentioned, and Charbel Elhaj, two of our research fellows, have a paper coming out, a big paper coming out next month in about 4 weeks, looking at predicting pulmonary failure, predicting who needs a component separation, and predicting wound complications by AI, just looking at the preoperative CT scans, totally objective data, no data from the clinic other than the CT scan. And it is scary how good the computer is with AI. We don't know, we don't even know what the computer is looking at. It just looks at every single slice of the CAT scan, got itself trained, and then we then compared it to expert surgeons predicting what we thought would happen by looking at a CAT scan, and the computer completely schooled us. And so,
yeah, thanks, Todd. Yeah, thanks. I guess what we're alluding to is that, I mean, we need some way to change the paradigm. And we simply can't go on like this, making data-free statements. As much as we're all surgeons and love the technique part of it, I think we need to bring this other element into it. If we don't do it and you don't have the courage to change it, someone will force it on us, and that would be not a great option. I don't think anyone else is qualified or has the ethos to change this. So I think this is a great start. I don't think we have all the answers, but I think it's new solutions to new problems, and we're hoping this will give us a lead.
Thank you, Dr. Hensman, and thank you, Dr. Khurana, for that wonderful insight.